Good evening, friends. Today I have brought some quizzes for you, which are from pediatric nephrology. So I'll be showing you some pictures of investigations and some X-rays and some other diagnostic modalities. And I will be asking you questions. Okay, let's see if you can accept the challenge and if you can give me the correct answers to the questions that I will be asking. So let's start. And most of these questions would be from the area of pediatric nephrology. Okay, so let's start with the very first one. So here you see two bottles and they have got urine samples in them. The first one is the fresh one over here. So this is a sample of fresh urine given by a child. And after some time, it changes its color to almost black. Okay, so the sample of urine has changed color, and this especially happens when it's exposed to the air. And the question is, what's your diagnosis? Okay, so remember, when urine changes its color on standing to black, the diagnosis is very straightforward. We call it L-captonuria. So I will just write it over here. L-captonuria. And L-captonuria is actually a metabolic condition in which there is problem with the breakdown of tyrosine and phenylalanine, which are the amino acids which are required by our body. And there is a specific enzyme which we call as homogentasic acid deoxygenase. So when this enzyme is missing, there is actually accumulation of homogentasic acid. This homogentasic acid is then excreted in the urine as well. When its level builds, it can get deposited in the cartilage and bone as well, and that gives problems with joints, it gives problems with bones, it can be deposited in liver, it can be deposited in heart, okay, it can give you different types of problems. So the question, what is the abnormal component in urine? So this component is homogentasic acid, okay? So homogentasic acid, which actually changes color to black when it's exposed to air, homogentasic acid. And the deficiency is the enzyme homogentasic acid deoxygenase. And this disease is usually transmitted in autosomal recessive condition, especially in consanguineous marriages. So let's move on to the next question. Let me erase this one. And we move on to the next question. Yes, okay. So here you see an X-ray KUB, okay, which is showing you very classical signs. And if you see, you can see calcifications, okay, in both of the kidneys, okay. And these calcifications are so dense, they have almost taken the shape of the kidneys, okay. So what is the diagnosis? The diagnosis is when you've got calcium stones filling up both kidneys, we call it nephrocalcinosis, okay. So these are two kidneys which are full of calcium stones. And then the question is, mention three possible causes. So what are those three things that can give you this condition? And it's quite painful because when you've got stone in your kidneys, okay, and the kidneys tries to expel it, it's a very painful condition. It will lead to recurrent abdominal pain. So the three possible causes, number one, if you've got increased calcium levels in your bloods, okay, and those calcium then, goes into the kidneys, okay, and can get deposited over there. And this happens because of primary hyperparathyroidism, okay. So if the hormone is more, you'll be having more calcium in your blood, okay, and that can precipitate in the kidneys and give you nephrocalcinosis. So one is, I'll just write quickly, primary hyperparathyroidism, okay. Number one. Number two, what else can give you this thing? Type 1 renal tubular acidosis, okay, which is also known as the distal renal tubular acidosis. And distal renal tubular acidosis, the urine is quite alkaline, and there is hypercalciuria, and this increased calcium in the urine can get precipitated in the renal tubules and can give you a nephrocalcinosis. So second is type 1 RTA, renal tubular acidosis. And the third thing in which you get increased calcium in your blood is sarcoidosis. So sarcoidosis is the third condition. It's an autoimmune condition in which you get hypercalcemia, and that hypercalcemia can manifest itself by depositing in the kidneys and can give you nephrocalcinosis. So three conditions that can give you nephrocalcinosis. Remember, number one, primary hyperparathyroidism, that is increased parathormone in your blood. Number two is type 1 distal renal tubular acidosis. And number three is sarcoidosis. So all these three conditions are characterized by hypercalcemia, and then eventually that would lead to deposition of calcium in the kidneys. Okay, so let's erase this one. And let's see what's happening. It's not getting erased. Okay, so let's move on to this third image. So what is the abnormality? So if you see here, this is basically an intravenous urogram, excretory urography, okay? And you can see on the right side, you can see the renal calyces and the right side ureter, which is going down and opening the bladder. The bladder is also full of the dye. And on the left side, you can see there are two ureters. So this is, go it over here. So this is the first ureter and this is the second ureter. So the left kidney, you see over here, has got two ureters, 1 and 2. And the first ureter, which is on top, is actually going behind the first one, because behind the second one, okay? And eventually both of them, they have got different openings in the bladder, okay? And the clinical significance of this condition is that usually the lower one is actually inserted at an abnormal position. So you get vesico-ureteric reflux. So in this condition, there will be more reflux going back to because there is the sphincter is not properly functioning. So there will be reflux of the urine back into the ureter, and it will eventually go up and damage the kidney. It will cause long-term scarring, renal scarring in the left kidney. So the abnormality is duplication of ureters, ectopic ureteric insertion, and the clinical significance is that it would lead to vesico-ureteric reflux, and that would eventually lead to renal scarring and may end up eventually in chronic renal failure. Okay, guys, so moving on to the next question. Let's erase this one. And we move on to the third one. Yes, so I will just focus on this lower one for the time being, okay? And again, here you can see very dilated and tortuous left ureter and a dilated left pelvic calyceal system, okay? And again, this is caused by severe vesico-ureteric reflux, okay? Because either the insertion of the lower ureter is not in a proper position, or sometimes if it is bilateral, then it can be caused by posterior urethral valve as well, especially if the child is a male. But in this case, it is unilateral, so you can see a very dilated left-sided ureter, and you can also see that the pelvic calyceal system is dilated, okay, and that can lead to scarring, okay. So it's important that we do an ultrasound, and we also do, though usually in these cases ultrasound has already been done, but the important modality would be to do a Dmsa scan to see if the kidney has got scars or not. Okay, moving on to the next one. Okay, and this is what we call as a technetium Dmsa scan, okay. And here you can see this is the left here. Let me draw it for you. So this is the, sorry, you're seeing it from behind, okay. So this is the left one, okay, and this one is the right kidney, okay, because in Dmsa scan, when you're seeing actually the images are taken from the back side, so when you are looking at from the front, your left side is actually the patient's left side as well, okay, and your right side is the patient's right side as well. So here you can see this one is in a proper shape, okay, so you can see the proper kidney shape over here, but here you see that there is dent, so the dye has not been uptaken in this region, so it means that this area is not properly functioning and there is a scar over this area. So this area has been damaged by repeated reflux or something. So this area has been scarred. So here you see a left renal scar in the Dmsa scan, okay, and it is usually caused by vesicoureteral reflux. Moving on, but let me erase this one and we move on. Okay, fine. So if you look at, let me slightly enlarge this one. Okay, so if you look at this image, okay, this is actually what we call a palpable rash, okay, on the buttocks of probably a 4 or 5 years old child, and he's got hematuria. So his urine contains blood, okay, and when a child has got hematuria and he's got this type of rash on the lower limbs, it could be on the extensor surfaces of the upper limbs as well, sometimes, rarely, but most of the time it's on the hips or on the ankles, okay, or on the shin. We call it palpable purpura, and the condition is known as HSP, spondyline purpura. And mentioned two other symptoms. So this is actually associated with arthritis. So you've got joint pains. Child has got abdominal pain as well, and there is a palpable purpura because this is basically vasculitis. So it is raised, and you can feel it with your hands if you try to rub onto the rash. Okay, moving on. Look at this condition. So this is probably a 6-7 years old child, 6 years old, as the caption says. He has had a renal transplant because he was suffering from chronic renal failure, and now he presents with a blood pressure of 170/90, which is quite raised for this age, and his LDL, that's the low density lipoproteins, are quite increased. Okay, so what is the diagnosis? So in a child who has had renal transplant with a high blood pressure and deranged lipid profile, this is a side effect of the immunosuppressant therapy, because when you have transplanted it, you have to suppress the immune system to reduce the chances of graft versus host reaction. And the drug which is commonly used in renal transplant is cyclosporine. And cyclosporine, one of the common side effects of cyclosporine is that it causes deranged lipid profile, and it leads to hypertrichosis as well. So if you see here, the child has got hypertrichosis, he's got a lot of hair, okay? Normally shouldn't be having the adult pattern hair, okay, in this age. And this is known as hypertrichosis, and this is one of the side effects of cyclosporine. Okay, moving on. Let's move on to the next one. Okay, so these are the autopsy findings from a child who died because of renal failure, and the kidneys are shown. So both of the kidneys, you can see what is the diagnosis. So if you see the kidneys over here, so they have got multiple cysts, okay? Can you see these multiple cysts, okay, of different sizes? And this is what we call as polycystic kidney disease. And polycystic kidney disease is of two types. One is autosomal dominant and autosomal recessive. The autosomal dominant polycystic kidney disease usually manifests in adult life. Okay? You don't see that very commonly in kids. The kids have got the other, what we call as the recessive type of polycystic kidney disease. So this is autosomal recessive polycystic kidney disease, okay? And mentioned two other clinical associations. So this is usually associated with what we call as problems with renal dysgenesis, and it is also associated with hematuria and hypertension. Moving on to next slide. Okay, so here you see this is an image of urinary bladder, and you can see that there is dye in the bladder, and then there's dye in part of the urethra as well, but then you see the dye is not going forward. Okay, so this investigation is known as MCUG. This is micturating cystourethropography. Okay, and This condition is known as a posterior urethral wall. So this happens in male child. So there are posterior urethral walls. Okay, and because of that posterior urethral walls, what happens? There is one-way, traffic of urine, and it leads to backward pressure. Okay, and that can then go into the ureters, through the blood into the ureters, and can cause vesicular reflux, and ultimately repeated urinary tract infections, and ultimately chronic renal failure secondary to repeated urinary tract infections. Okay, guys, so further moving down now. Okay, this is another image in which you can see this is the, again, an intravenous urography, and you can see multiple dilated bilateral renal calyces, as well as bilateral dilated ureters. And again, this is caused by severe vesicouric reflux, and it would eventually lead to bilateral renal scarring and chronic renal failure. And if you see, these are the associated X-rays, and in this X-ray you can't see much of the lung fields. Okay, and this is because of pulmonary hypoplasia. And sometimes if there is pulmonary hyperplasia associated with renal problems, we call it as Potter sequence. So what happens, there is renal dysgenesis or agenesis, and because of that the fetus is not producing enough urine in utero, so there's not enough of amniotic fluid, and because of less amniotic fluid, what happens is that the lungs are not properly developed. There will be pulmonary hypoplasia, okay, and there would be also some facial anomalies as well. We call it as Potter sequence. So it can be associated with Potter sequence. This is image of a child who has got some rash around his nose, okay, small papules, okay, oily papules, and this is known as Adenoma Sebaceum. And Adenoma Sebaceum is one of the conditions which is associated with tuberous sclerosis, okay. And I say if it has an abdominal mass, what it would be now. In tuberous sclerosis, the masses that are usually associated with that are angiomyomas, okay. Lipomas, sorry. So angiomyolipomas are usually the common masses which you find in kids who have got tuberous sclerosis. So if they had an abdominal mass, most probably it would have been angiomyolipoma. And this 4-year-old male has hypertension and microscopic hematuria, and you can see there is an abdominal swelling. Okay, so what could be the cause of the abdominal swelling in this age? Okay, so a child who's got hypertension, microscopic hematuria, okay, you should think of renal malignancy. So Wilms tumor should be the top on your list. Other conditions that can cause neuroblastoma can also rarely present with hypertension and can cause microscopic hematuria. And the third thing is hydronephrosis. So if the child has got severe bilateral hydronephrosis, it can also present with big abdominal swelling. Mentioned 2 investigations. So of course, the first line of investigation would be an ultrasound, renal ultrasound, okay, which we tell you. And the next investigation, there are different school of thoughts. Like somebody would say, if you are suspecting renal pathology, you might go with the Dmsa scan, but probably if you're not sure about that, CT scan would be the best next step after an ultrasound has been done. Okay, so this is a picture here. You can see that one iris is different from the other one. And this is known as a heterochromia iridis. Okay, so one is different from the other one. There are different conditions which are associated with this condition. So if he's got a unilateral abdominal mass with the diagnosis, it can be associated with Wilms tumor, nephroblastoma. Okay, rarely could be associated with neuroblastoma as well, but mostly Wilms tumor. Okay, so you have to exclude that. Okay, look at this condition. A child who's got bilateral swelling of the orbits, okay, and there are raccoon eyes, okay, bilateral panda eyes or raccoon eyes, okay. So you are seeing that, and 2 possible causes. Number 1, non-accidental injury, okay. especially in this age group. Okay. Head injuries can also cause, like, fracture of the base of the skull. But usually in kids, one should suspect non-accidental injury. So that should be the first one. And the other thing that can cause bilateral raccoon eyes are metastasis from neuroblastoma. So neuroblastoma can also present with bilateral raccoon eyes, panda eyes. So this is the lily sign, okay, which is seen in many different problems. And here you can see a child with strawberry hemangioma. And together, lily sign on an intravenous pyelography with the strawberry hemangioma, okay, you should think of neuroblastoma. So neuroblastoma is basically a tumor of the sympathetic nervous chain, and it can happen anywhere. It can arise from the neck down to the chest, down to the abdominal cavity, can occur anywhere, okay. Most of the time it occurs in adrenal glands, but can usually occur in chest cavity as well. Okay, this patient presents with high-grade fever. He is comatose, had 2 previous episodes of generalized convulsions. Okay, the blood pressure is quite low, 90/60. Sodium is also low, hyponatremia. What is the sign? Okay, so this is purpuric rash. The diagnosis is meningococcemia, the dreaded purpuric rash of meningococcemia. Mentioned 4 points in management, so obviously this is a medical emergency. This child needs IV fluids. This child needs IV antibiotics. This child needs supportive treatment in the form of oxygen and supportive therapy. Okay, and this child would need intensive care treatment, maybe even steroids. Okay, if he's going into an adrenal crisis. How to treat contacts? Most of the time, we give rifampicin to the close contacts. In elders, you can also use ciprofloxacin. So ciprofloxacin and rifampicin are usually used to treat the contacts. So this was a short quiz on different diagnostic modalities from the field of pediatric nephrology. I hope you have enjoyed it. Give me your comments if you liked it, so I can make some more quiz-based videos for you. Have a good evening. Thank you. Bye-bye. If you've got any question or comment, just put down in the comment section. Okay, do subscribe to my channel. Thank you and bye.